everyone. My name is Tammy Martin.
And I'm John Martin.
And we are the founders of Young Black Leadership Alliance. YBLA is a nonprofit organization that focuses on building leaders in young Black men and women, starting in high school, through college, and into their young professional years. Our program is based on 3 pillars. It is leadership, service, and education.
Awesome.
Our mission is to build leaders that will make a positive impact on their peers, community, and eventually the world.
Awesome.
Yeah.
First, we want to thank our partners at DHG for starting the
Yes.
charge on this initiative to end racial injustice and inequality in the Black community. We thank them and their team for supporting us and helping making this a reality. If this is your first time joining us, the YBLA Community Conversation Initiative is about taking a stand up against racial inequality and injustice. We're using the acronym STAND to describe the initiative. STAND is for seize the moment, talk to others, act on your biases, no more silence, and donate your resources.
Yes.
We invite you to stand with us to make a better tomorrow in the Charlotte community. We have a target goal of achieving 2,020 actions towards bridging the gap of racial disparities.
Yeah, that's right. So welcome everyone to the 11th segment of YBLA Community Conversations. Today marks the 5th session of phase 2 as we take a deeper dive into the racial disparities that has plagued the Black community. Today we'll be discussing healthcare disparity among Blacks. So far, we have discussed employment, housing, criminal justice, and education disparities. But if you missed any of those conversations, no worries. Please visit our website at youngblackleadership.org/community-conversations.
So we're going to bring up our amazing young leader, Mr. Abuna. So you'll see on the slide an update on our progress on our 2020 actions. Abuna, what you got?
Yeah.
Good morning, everybody. My name is Abuna Uche, a junior from Ohio University. And right now we are at 1,167 actions.
All right.
That means we are 58% towards our 2020 action goals.
All right.
Awesome, awesome, awesome. So we are so very excited about being at 58%, but we're not satisfied with that, right? So we want to take that even higher. We would love to drive that higher. So today we're going to give everyone on the call an opportunity to complete a call to action.
Yes.
So on your screen, you will see 10 of the past call to actions. Each of them is designed to drive action towards racial equality. So in that first screen, on the first slide, you'll see the first one is invite your network to join the community conversations. That is so easy. We want to make sure you guys get that done. The second one is sign the I Stand for Racial Equality petition. Again, yet another easy one to do.
That's the easy one.
We had 2 times where we asked you to share a post from our social media about facts about Black women and then facts about Black men. And then we also asked you to support a Black-owned business and then also support Black-led nonprofits.
That's right. And the next slide you will see, we ask that you share what your company is doing about employment disparities. We asked you to watch the Brooklyn video and also email a letter of concern to the Charlotte City Council members. And last but not least, we asked you to purchase a STAND t-shirt. Now, last time we wore that t-shirt, right?
Absolutely.
So, but what we decided to do is extend the deadline. So you will have all the way to Friday to purchase the shirt.
All right, so we're going to do something a little bit different. So we're going to give you guys 2 minutes to complete 1 call to action. So we're going to make this super easy for you. We picked out 4 call to actions, and we ask that you work through 1 of them. If you've already done 1 of them, don't worry about it. Just do the other one.
Yes.
So the first one is to purchase a YBLA Stand t-shirt.
That's it.
As mentioned, we extended the deadline. Abuna is going to drop the link in the chat so you guys can get that done. The second one is if you haven't signed the I Stand petition, go ahead and get that done. Again, it's easy. It's 3 or 4 small questions and would be great. And again, Abuna is going to drop all these links in the chat for you. The next one is donate to a Black-led nonprofit. On the slide, we showed the 5 different nonprofits: YBLA, Harvest Center, Stiletto Boss University, Profound Gentlemen, and Samaritan's Feet. And finally, in the chat now, can you share what you or your employer has done towards racial equality?
Yeah.
So again, really easy right there.
Right. And even if you watch the documentary 13,
Yep.
let us know that, because that was also one of the call to actions that we slid in there.
Yeah.
Along with the Brooklyn video, if you've seen that, feel free to drop that in the chat, and then we can count that towards our actions today.
Yep. So you've done any one of those, let us know. We're going to give you guys, again, 2 minutes to go ahead and get that done.
Yes.
Abona's busy getting those in there, getting the links in the chat. I would love to look. I can see the chat. So if you guys have something in there, if drop in the chat something that you have done towards racial equality or something that your employer has done. Definitely.
Any of those we can count towards actions.
Yes, yes, yes. There's a question in the chat about picking up one of our t-shirts. We'll actually send you a t-shirt. So if you just go ahead and order it, we'll go ahead and get that sent out to you.
Yeah, they will be mailed.
And we're going to place the order when?
It will be after Friday, because we extended the deadline to Friday the 23rd. So after that is when the orders we will place the order. So you should have your shirt by the middle of November.
Okay. Yeah, I would love to have a day where we all can wear the shirts on the same day. That would be awesome.
Yeah.
All right, as we're getting close here, we're about to wrap up. Abuna, can you show me a couple more that's in the chat there? Oh, he's never mind. He's busy putting the links in there. So I love it. I see some folks from DHG, from PwC in Charlotte.
Yeah,
we got someone from, is that Arkansas? Ah, awesome. Got someone from Mercer. Awesome, awesome. Atlanta. Got some folks from Bearings, Belk. You guys are so awesome.
Yeah.
Awesome.
We
got someone from South Carolina. Yes, someone watched 13th. Thank you. We got two people.
Good deal.
All right. Companies matched the racial justice, matching donations, made a donation to YBLA, watch 13. Hey, Kate. Thank you, Kate. Awesome, awesome, awesome. Well, let's go ahead and move that thing forward, because I think we're right on time, because that's 20 seconds left behind.
All right. Okay. So today, we are going to talk about racial disparities in healthcare. So I am going to bring on our astute panel. And actually, this is one thing that I must say that has been near and dear to my heart, because I actually worked 25 years in the healthcare industry.
Yes.
As an occupational therapist before I turned to move into the nonprofit space. But before I introduce our panels, I wanted to do a quick true-false poll to see how much you guys know about the healthcare disparities. So I'm going to have our leader here, Abuna, is working double time over here, and to put up the poll, and we're going to give you about a minute.
Yes.
And it's 5 questions, true, false, real quick, and we just kind of want to gauge and see where the audience is on what you know about healthcare disparities.
Yeah, so we want to see how you guys do. So you got we got about a minute here to take the poll. So if you guys would go ahead and get that done, it should be on your screen right now. And we will go through the answers here in a minute.
Yeah, and we see how well you do. Okay, give you a few more seconds there.
Yep. If you're on an iPhone, you might not be able to see it, but if you're at your computer, you probably will be able to see it. It should be on your screen.
Okay, Abuna, can we have you?
They're just wrapping up. I still see a couple more coming in.
You
42,
still see them?
51.
Right.
Yep.
Yay.
I'm going to give you about 11, 12, 13 more seconds. Yeah, we're up to a good number. Absolutely. All right, let's see what we got.
Let's see some results.
Yes.
All right, we're going to go through these real quickly and just see how you scored.
Let's see what we got.
All right, first one, we asked about the life expectancy for Blacks. And what did we get?
Oh, they did awesome.
Oh, yeah.
All right.
It was false. That is exactly right. 91% said it was false. You are correct. Actually, the life expectancy for Blacks is 75. For whites, is 78. Asians is actually 86.
Awesome. We got a really sharp audience today.
Yeah.
Awesome.
The second one, again, on life expectancy, we asked, does your life expectancy can be determined by your neighborhood? Wow, 95%, you got it. That is so true.
Yeah, they got all the answers. We got the right group here.
Yeah.
All right, let me see if they got this one. All right, so the next question seems like a layup for everybody. Black people receive lower quality health care than white people, even when insurance status, income, age, and severity of the conditions are comparable. The audience said 93% of them said that is true, and that is true. Right. Unfortunately, it is true. So I think we are telling folks what they already know, but it's an unfortunate reality.
It really is.
The next one, I'm going to see what they got on the next one.
The next one is what really shocked me about Black women, specifically Black women with college degrees have higher maternal and infant mortality rates than white women who dropped out of high school. So I thought that was an interesting comparison. Yeah, and the audience, 87% says true, and that is exactly right.
Yeah, that's an interesting one because a lot of people think data is based on education and poverty level.
Right.
And this one says the exact opposite.
Flip
of that.
opposite.
Absolutely.
And the last
All right.
one.
So the last one I think is a layup for everybody. Compared to white patients, Black patients were 40% less likely to receive medication to ease acute pain. And we have 93% of the folks out there said that is true, and that is absolutely true.
And you are correct.
Absolutely.
All right, we're a smart audience today.
Yes.
At least our questions wasn't hard enough. Maybe one or the other.
We got a smart audience.
Okay, Abuna, we're going to start.
Thank you, everybody, for rolling that up. And thank you, Abuna, for putting that poll up. We definitely appreciate that. We wanted to do something a little bit different.
Yeah.
Yeah, absolutely.
Okay, now on to the conversation. As you have seen from our poll, we took that Black people are dying earlier and not receiving the same quality of health care that their white counterparts receive. So we wanted to address 3 areas today on the panel. And when it comes to health disparities, and that is physician bias, access to quality health care, and lack of health insurance. So now I want to dive in and meet our astute panelists. I will start with one of our very own board members of YBLA. We're going to start with Rocky. I want you to kick it out for us. Rocky, I want you to introduce yourself, give us your name of your employer, your title, and we want you to answer one question for us. The question is, what grade would you give our healthcare system in Charlotte when it comes to racial equality? So, Rocky, take it on.
Thank you. Greetings, everyone. First and foremost, I just want to say thank you to John and Tammy Martin for the exemplary example you are within our community and the impact. Certainly, there's intent by many. The impact by some falls short. Certainly, you all are exceeding expectations on intent and impact. So thank you for that. In regards to myself, Rocky McGregor, I'm the Vice President of Community Engagement and the Chief Operating Officer for our Consumer Strategy and Products area. I'm happy to be here. I will tell you that from the standpoint of the grade that I would give our healthcare system as it pertains to racial equality, I would give us a B. And if I may, I would just say that that comes from a place of not just how we're doing by listening to our community first. It also is how I evaluate what we look like from an executive team, what we look like from a senior leadership team, and how well that aligns with those that we're looking to service. And then lastly, but certainly most critical, how we are engaging with our community to understand through their lens what it is that we can do better for them. So I'm happy to be here and looking forward to the conversation.
Thanks, Rocky. Okay, we'll move on to Miss Donna. Donna, introduce yourself.
Afternoon, everybody. Tammy and John, I first have to thank you for including me in this conversation. This is a topic that I've been very passionate about for most of my career, probably my entire career in healthcare. Currently, I am engaged in physician assistant education. I'm a PA. I've been a PA for 24 years. and transitioned from clinical practice 6 years ago to become the founding clinical director for the PA program at Lenore University. Currently, I have the blessing of working between two PA programs, the PA program at Pfeiffer University and the PA program at Gardner-Webb University. And one of the things that I am passionate about that I work with students on right now is issues around health disparities, most particularly social determinants of health. And as you know, recently I did complete a doctorate with a concentration in PA education, and the focus of my work was in the area of social determinants of health.
Nice. So what grade would you give the healthcare system, Donna, when it comes to racial equality?
So Charlotte in particular, I would say right now we're at a C, and I think I'm being very generous.
Okay.
There's a lot of work that needs to be done around access and access to quality care. And the mental health space is definitely lacking.
Hey, Donna, we have a very smart audience, but I know that I struggle with the concept of social determinant of health. Can you give me one sentence to describe what that actually means?
So Tammy actually mentioned all of the social determinants of health in her introduction to what this conversation was going to be about. And basically, we're talking about access to healthcare, education, employment, things such as childhood trauma even come in, issues around substance abuse. Those are things that would come into play when we talk about social determinants of health.
So cool. does it mean like all of those things determine what your health is? Is that kind of the way to summarize that up?
They come into play, yes.
Okay,
Gotcha.
Great.
All right, Dr. Mary, please introduce yourself.
I am Dr. Mary B. Gaffney, and I am the owner of Gaffney Health Services currently. My background is in emergency room medicine and family medicine, but this practice is full scope family medicine. So we're kind of a grassroots voice in the city of Charlotte that treats everybody and anybody. So my waiting room can span from a corporate executive to the mom in the waiting room with 7 kids. And our voice in Charlotte is very important. We feel it is, myself and my staff, because we treat the people that have been forgotten, or the people that have been overlooked, or the people that really are at highest target for the most ominous outcomes. And I think that we're really doing a service to the community.
Awesome. Yeah. Your mic is really low.
Yeah.
So I'm going to get you to speak up on that
right,
while we fix this. Yeah.
Very
yeah.
good.
Yeah. And Dr. Mary, I want you to give a grade on what do you give the Charlotte healthcare system when it comes to racial equality.
I have to agree with the PA. Definitely a C.
Okay.
And that's being quite generous. Until you've been to the other Mecca universities and communities of the Mayo clinics, of the Cleveland clinics, of the Brigham and Women's, you don't realize how much we're really lacking in our system and in the processing of our patient care and our outcomes. It's very, very concerning at the least.
Yeah.
Awesome.
All right. Thank you, Mary. And we'll move on to Mr. Jerome. You want to take us on home?
Yes, thank you. Happy to be here. Thank you for inviting me, John and Tammy, but more importantly, thank you for your leadership in the community and leadership of YBLA and the phenomenal work that both of you are leading in our community. So thank you for that. Dr. Jerome Williams Jr., Senior Vice President for Consumer Engagement for Novant Health. I'm also by training cardiologist. I only practice 1 day a week. However, in my role as Senior Vice President for Consumer Engagement, I'm responsible for our strategic direction for our community wellness, community benefit, corporate social responsibility throughout our system, with a focus on social determinants of health. The grade I would give the overall healthcare system in Charlotte, there are really 2 healthcare systems, Novant, HM, and then there's the Mecklenburg County Public Health. So if you take all of those collectively, I would probably say a B. B, depending on which systems you're looking at, if I'm speaking at Novant, I'll probably lean more toward a B plus. I'm sure there's some bias in there as well. However, the reason I say that is that, health, and Donna mentioned it earlier, health is really, or the vast majority of our health really has nothing to do with biology and genetics. 80% of our health has to do with social determinants of health, which include lack of housing or housing insecurities, food insecurities, lack of upward mobility, lack of social capital, lack of safe neighborhoods, okay? And so when you look at the constellation of social factors that impact health, you then realize that the way healthcare systems are set up, historically, they were not set up and still are not set up to address the social determinants of health, which has the greatest impact on the individual and a community. And so there's a lot of work to be done, but I would suggest that work is not only of healthcare systems, but of many different organizations that need to come together in a collaborative way to address many of the challenges that our communities face.
Wow.
Awesome.
Great answer. You almost answered the first question I was going to jump in, because I wanted to get a perspective from all of y'all on, in your experience, because all of y'all come from like little different backgrounds. In your experience, what would you say are the main health disparities that are impacting Blacks, and what solutions are being put in place that you have seen?
I'll just jump in there. So when I look at the disparities, there are disparities all across the spectrum of health. Right. So you mentioned you mentioned maternal health. There's disparities there. There's disparities in outcomes from heart attacks, strokes, the list goes on and on and on. You can open up any medical book, close your eyes and pick any diagnosis, and I guarantee you there will be disparate outcomes between people of color and in the majority. Now, that said, what we have to look at what really kind of causes, what's the foundational cause for a lot of those disparities? And many of those causes come from inequities outside of healthcare, right? So just plain and simple, we start with racism, okay? Just straight up racism leads to inequitable activities in communities. So inequitable distribution of services, inequitable distribution of healthy foods in supermarkets throughout neighborhoods, inequitable distribution and opportunities for employment, inequitable opportunities for education. All of those inequities throughout society then contributes to poor health, And so what we have to do is really go upstream, way upstream, and see foundationally where some of the challenges begin. And often they begin at birth, even before birth, some of the challenges that our communities experience.
Mm-hmm. Rocky, I know you talked about in some of our board meetings on what Novant is doing as far as solutions in place to try to move the needle on racial disparities among Black. Can you shed any light on what Novant is doing as a solution to this problem?
Sure. And there are many things that we're doing. The reality is what we're laying is the groundwork for generational change. I just want to start off by saying that everyone on this call, I believe, knows that the actions that all of us are taking, we're looking to make great impact, certainly with the awareness that's currently been placed upon us by a number of unfortunate events that have taken place. However, this is laying the groundwork. So answer your question more specifically, Tammy, we are, one thing I'll tell you that we're doing internally, we have.
Oh, we lost your volume. We lost your mic,
okay?
Rocky.
Can you hear me okay?
Yeah.
Yep.
Can you hear me okay? Okay, my apologies. We have developed a program led by our President of Physician Services, as well as our Chief Diversity and Inclusion Officer, Pam Oliver, Dr. Pam Oliver, and Tanya Blackman, respectively. And what they've done is they've created this My Grow community, which is a playoff of micro communities. And they've brought together physicians of color. And in talking to those physicians of color, they want to afford them an opportunity to talk about their experiences and how they see what we're going through impacting themselves and their patients. And they're also leveraging these physicians to go back and talk to other physicians that are within their practices, really to create optics and awareness of how what we saw happen to George Floyd is impacting all of us. That's one thing we're doing. Another thing that we're doing from a community engagement perspective is we are engaging with our communities through our community health workers. Our community health workers are affording us an opportunity to get optics, insight into what are our communities within Mecklenburg County, Forsyth County, other counties that we're in within North Carolina, Brunswick County. What are they feeling, and how is that impacting them? There is a gentleman, Dr. Williams, who on a TED Talk spoke about racial inequities, and he talked about it from the standpoint of racism is killing us. The reason racism, he says, is killing us is because of the impact that trauma that AP Dr. Murray mentioned, that trauma is actually perpetuating the social determinants and the impact that they have on our body. And what he further talks about is how a African-American male who has a 4-year college degree has a life expectancy less than a white male with a high school degree. Why is that the case? I will tell you that it yields to his research yields to the racial inequity. The last thing I'll say that we're doing is we're partnering with Charlotte Mecklenburg. We're partnering with Atrium, and we're looking at how we can come together to understand, again, where these disparities are that Jerome and others have mentioned, how they can be rectified by us collaborating and coming together. So what Mecklenburg County has done is they've created a proclamation to identify racism as a public health crisis. And
Wow.
that, as a result of that, that was in June. As a result of that, we and other corporations, nonprofits can then link onto that, create programs to where, as Jerome mentioned earlier, we create upward mobility, right? So how do we go in and create a livable wage for those who are not looking for a handout, but truly looking for a hand up? How do we afford them opportunities to, from a workforce standpoint, from an education standpoint, from a housing standpoint? So we've also loaned $6 million to affordable housing so that we can assist not just with acquiring the home, but how do we also support those who are looking for opportunities to understand that getting the house is one thing, but actually maintaining and keeping the house is another. Last thing I'll mention is food insecurities. Food insecurities, as Jerome mentioned, create challenges that perpetuate or exacerbates, I should say, those health challenges that we face, diabetes, cardiovascular. So how do we get those foods into the neighborhoods that are not readily available there? And we're also doing that through our collaboration and partnerships. So that's just a little glimpse of some of the things that we're doing. And I'll also say that we opened up another Michael Jordan clinic last week, our second Michael Jordan clinic, so that we create a medical home inside the underserved communities so that they don't have to go outside of their neighborhoods to provide, to have a medical home.
Wow. Thanks, Rocky. Y'all doing some amazing work at Novant. Wow. I want to bring Dr. Mary in. Mary, what type of solutions do you have in place, or that you want to put in place to help diminish the healthcare disparities amongst Blacks in your patients? Because you own your own practice, so you're coming with coming from a different perspective. So
I do. And my perspective is it's very much old school. Having studied under Dr. Thatcher, when America gets a cold, Black America gets pneumonia.
yeah,
We know that what the outcomes data look like of the people that are in the average community. And thank you, Novant, for what you're doing. I feel like I'm part of the Novant family as well, having committed my life for 21 years to Novant staffing. But I think education is crucial in small practices. So people come to small practices because perhaps they're seeking, not necessarily what is, but are seeking a more personalized relationship. So you see the same physician over and over again, or that physician knows the patient, the grandparents, the children, and the great-grandchildren. I've been fortunate enough to see generations in my practice and watch kids go off to college and kids go on to professional schools. I think the determinants clearly do reflect where we as a community will go as far as statistics of childhood birth rates that will depict outcomes of educational levels of newborn infants, of the pregnancy levels, of the STD exposure levels, of the overall health care of our young adolescent females and males, and even looking at vaccinations and the opportunity to have vaccinations in the private practice settings, as opposed to depending upon sending the patients to the pharmacies to have to, of their own will, to get immunized. So all those pieces, educational pieces, are housed in the private practice. And the more services the private practice can offer, I think that is, and education, that is the key to seeing some changes in the determinants, or at least putting a dent in them for better outcomes.
Awesome answer. Speaking of education, Don, I want to have you jump in here and talk a little bit about racial bias from physicians. And I know you're on the front end of getting doctors there. So I want to get a little bit of that. So the question I have is, what kind of control is there? So what kind of control is there? And then how can physician bias be prevented?
So, interesting question, and thank you for posing it. Again, this is the space that I currently work in. I'm training young clinicians who are coming behind me and behind Dr. Gaffney and behind Dr. Williams to do the work that is upon us right now. Right. And I'm actually working with students from both of the programs that I work with on issues around implicit bias. So for those of us who work in the education space, either full-time in the classroom or in clinical settings as preceptors, it's incumbent upon us to make sure that students are self-aware and reflective about their own implicit bias. So that's the way to combat what could happen on the other side where they're actually seeing patients. It's interesting. Recently, I've had a couple of discussions in the class that I teach, cultural determinants of health, to one group of students at one of my programs, and I had them actually attend a webinar last week. And what came up, it was around pain, first of all, and how African-American patients supposedly experience pain differently than patients of other races, which we know is not true. And that all came out of a study that was done in 2016, where 40% of all white medical students believe that we experience pain differently. But what came out of that conversation was not just about the pain issue, but it was also about the maternal child health issue. And there was an article that was written recently, which is entitled, is the lack of Black doctors killing Black babies. So that just opened up a whole conversation for my students.
Wow.
Yeah. And what I experienced with them by posing that question to them and then adding something onto the end, is the lack of Black doctors killing Black babies, or is it something else, made them become very reflective about what their own implicit biases may be. So to go back and answer your question, John, we do have to begin educating young students, both medical students, PA students, nurse practitioner students, about the issues around implicit bias so that they can become reflective about what they may be bringing to their patients.
Mhm.
Wow, that's great.
And to piggyback on what Donna said, it doesn't stop there.
No.
It shouldn't stop there. It shouldn't
No.
start there. So to kind of connect what Donna said and what Rocky said as it relates to activities in Novant, we actually have what we call cultural sensitivity training that's led by Tanya Blackman, who is our Executive Vice President over Diversity, Inclusion, and Equity. And with that training, there was a baseline measurement, right, of our providers and their views. Then they went through training and then repeat testing, and there is a demonstrable difference, improvement after cultural bias training. This is not an optional training. Mm-hmm. This is of all individuals who have any kind of patient contact whatsoever. They have to go through this. And so while Donna's correct, let's get it way back when they're in school, okay? Understanding implicit bias, understanding, we all have biases. We all have bias. I even said earlier when I said, I think Novant gets a B+, and on average is B. Clearly there's some bias there. Let's be honest, right? But it's being aware that you have certain biases so that you can confront them and engage with patients. We do need more providers of color, but in the near term, that's not going to be realistic. And so we have to educate our non-African American brothers and sisters about implicit bias, about what's in their ground, where they come from, so that we can take the best care of patients possible and eliminate health inequities.
Right. Yeah, okay.
And those are difficult conversations to have. What I'm finding with my students is, most, and these are statistics that are real. Only 5% of all physicians in this country are African American. Of the 33,000 practicing PAs, only 3.6% are African American. So we're teaching students who are non-African American students. And we have to, what I say to them frequently is you have to become comfortable with being uncomfortable. And these are conversations that have to be had. Absolutely. Because if we don't have them, then it impacts patient outcomes on the backside.
Let's be clear. These students, just like all of us, we represent society, right? Right. And so when you take these students, just because they're accepted into a PA school, highly, a rigorous application process, really bright students, they're still from society as a whole. Mm-hmm. And we do understand that across society, there are differences of opinions. Right. There are biases. And so as they come into our programs, Donna's program, Dr. Gaffney's programs, our programs at Novant, we have to confront that in a real way. And I would also say that within our system, we are now at a point where that confronting those biases should not only come from people of color.
Right.
Right? It should be our white brothers and sisters when they hear something, when they see something. Right. They should be courageous enough to challenge inappropriate, statements, comments, thoughts, or whatever the case may be. It's not just our job It's the job of all in the healthcare system from the top all the way down.
Right.
Yeah.
And as we're talking about solutions, and I was telling you initially, I worked for 25 years in healthcare. I left Atrium, is where I worked. And one of the things that Atrium was doing is they put a lot of money in wellness. So they would incentivize, and I'm sure Novant has that's probably the same program. They would incentivize employees to stay healthy, go to the doctor if you joined a gym, if you had mammograms on time. So when we're talking about solutions, we do understand now that it's not a hospital issue, but it's a community issue, because that's what rolls into making the health disparity to begin with, is how you live, your access, and all of that. So if we flipped it as a solution, could we possibly have incentives for patients, just like Atrium did with employees? Do you think that could be a solution, where if the patients are given incentives for being healthy, getting their blood pressure down, going to a gym, the diabetes level, is that a possibility as a solution from a doctor standpoint? Or Rocky?
Well,
Yeah, and thank you for saying, I'm glad you clarified, because when you said doctor, I kept my mouth closed. I think the answer to that is yes, Tammy. And I think it's also yes and. So
Yeah.
what you're articulating, there are a number of different ways for us to do that, right? Certainly from an employment standpoint, what you just suggested is clearly, there are examples of that across the entire country. I would also say that at Novant Health, we're looking at workforce mobility. So for us, it starts with our team members, right?
Yeah.
So we have a percentage of our team members that come from the very communities that we're talking about, the very
Right.
communities that we all know are the worst in the entire country. So if we're going to talk about it, then we need to be about it first with those team members. We have developed career pipelines, and those career pipelines aren't, okay, we'll pay for you to go to school. It's, we'll pay for you to go to school, and we'll put a life coach with you, and we will support you with the dependent care that you have, and if there are transportation needs that you have. So it's how do we assist with those obstacles that are not affording those that are part of our team member population with upward mobility. And I mentioned community health worker earlier. We're growing our community health worker program. That is another position where we look to hire from the community. We want someone who's been through those that they're looking to support. We want someone who's gone through that journey, because all of us want to talk to somebody who has experience in what we're experiencing. So I think it's that, Tammy, and it's gone are the days where we just look at it from a healthcare perspective. That, if anything's you're taking away from this, if you're just looking at your healthcare system, whoever that healthcare system is, only from a clinical standpoint, you're missing the boat. We are a collaborator. So in order to collaborate, we need to go into the communities. We need to sit down and talk to, the Daryl and Melissa Gastons, on the West End. We need to understand through their lens, what is it that their communities need? And then we need to hold ourselves accountable for going and leveraging our relationship currency at Novant Health to bring individuals in. We don't have to do it all ourselves, but if we leverage the connections that we have, then we can provide access to healthcare, access to work, access to housing, access to food. That's where the real power of the healthcare system is showing itself.
Right. I love it. And Dr. Mary, what are you doing in your practice?
Yeah, I think you mentioned incentivize the community. I think Cheryl Emanuel has done tremendous work in that, in embracing the churches and bringing the incentivizing ideas to the community at large. I think that the outcomes have shown that if you do have an organizational piece, not necessarily corporate, but even community-based, that you can incentivize your community to improve or change those outcomes, those horrific outcomes that will affect everyone's life and community tremendously. I think we also need to bring to the table our FQHCs who are very active in the community as a resource and incentivize those patients as well with education and encouragement to pursue the same goals that perhaps a corporate incentive will be. If you get your cholesterol checked, these 7 parameters will take $75 off of your premium.
Mhm.
Yes.
So I think a collaboration is the only way that this can be done with everybody at the table.
And I'll also add, in addition to what Dr. Gaffney said, I want to piggyback on what she just said. Foundationally, what we also need is a culture change, right? We need a culture change. And one of the things at Novant that's taken place over the last 8 years, 7, 8 years, is a culture change on how we view our patients, right? Now, every patient is not the same. They have the same, pathway. So we have to change how we interact with our patients, which is a culture change. Well, how does that translate to what you just said, Tammy, about incentivizing patients? In a way, what you're saying is we really need to change the culture of our communities. We need to look at health as a shared value. We need to understand that, let's look at what's going on with COVID right now, right? Let's look at COVID's a great example about how a culture of health and health as a shared value would benefit our community. If from the beginning of the pandemic, it was clearly articulated and stated that what John does outside affects Dr. Williams, Dr. Gaffney, his behaviors does have an impact on the environment. And so if we as a community had a culture of health and well-being, right, which is a lot of the things that, Rocky and Donna and Dr. Gaffney mentioned outside the healthcare system, right? Nutrition, upward mobility, all those things, okay? I then think is less of a need to, quote, incentivize them in the long run. Mm-hmm. We have to buy into the fact that our health is by far the most important thing that we have.
Yes.
And we have to be a proponent of that. This panel here, we have to be a proponent of that. We do know certain foods are not good. Okay, we got that. Now, how do we make sure that certain neighborhoods have certain quality of foods? Okay. And then once that is in that neighborhood, then how do we continue to educate and say, hey, this certain food provides nutrition value. This is how you cook with this particular food. And then continue the education and enculturation process so that once adults understand it, kids understand it, when kids understand it at an early age, then it's on. As you're well aware of doing your leadership with YBLA. You get to the kids early on, then it's on.
That's it.
So I would really say, how do we continue to focus on demonstrating, educating, and leading that your health is vitally important in what you do? Behaviors contribute to that.
Wow.
I would agree with that, Jerome. I would agree with that. If you get the children, the parent, it's kind of like when you join a church. If the children are involved in the activities, the parents kind of come along. But that piece of how do we get the piece to the children on a large scale platform to make a change in a community or in a corridor, that's the fueling. That's the fueling.
Yeah.
I hope you can hear me.
Yeah, no, we hear you fine. Thanks. Yeah.
And to be quite honest with you, one of the major access opportunities we squandered as a state from a political standpoint. We didn't expand Medicaid. We didn't expand healthcare coverage. Yeah. That shot North Carolina in the foot. Let's just be plain and simple. Now, that's not the answer to all of the challenges, right? But that would have created more access to healthcare opportunities to then be able to screen for food insecurities and these other challenges that we talk about. So we can't get off of this webinar and not say the lack of expansion of Medicaid and or the Affordable Care Act to North Carolina citizens has dramatically hurt our population across the state.
Yeah.
I see that.
So that motivates us to get out and vote, right?
Yes, ma'am.
Yes,
You
yes.
nailed it.
Right.
Absolutely. Absolutely.
You want to go to the chat question? That's a good one.
Go ahead, we get it.
All right, yeah, because really a good segue into what Jerome was saying. One of the audience asked a good question, and we was wanting to go to health insurance anyway. So it says in addressing the 80% of health outcomes are socially based, is focus on insurance premium reductions through incentives really going to change things when there are major disparities on who has access to a corporate healthcare plan?
Ooh, great
That's
question.
a long question, but that's a good question.
Good one.
Does anybody want to tackle that one?
Jerome wants to take that.
So currently, if you look at how healthcare is set up, right, it's episodic and you treat the problem, right? You come in with a cough, what's the cough, treat the cough, et cetera, et cetera. Well, if the cough is coming from, poor air quality in your neighborhood because you live next to not too far from a landfill or something of that nature, okay? The answer is not just treat that cough, right? The answer is that whole community is being affected. So that's number one. What is reimbursed from insurance standpoint currently doesn't really address the social determinants of health. Quite frankly, myself and others are having discussions with insurers right now about if we know that 80% of the chronic health conditions are caused by social determinants of health, then why not reimburse for those activities to mitigate, right, the bad effects of social determinants of health? So some of those conversations are going on right now. The insurance industry is a very complex industry. The healthcare industry is a very complex industry. And that's also part of the challenges. It's so complex that even individuals who are on this panel who are in healthcare have trouble navigating the healthcare system from time to time. And we are within this healthcare system ourselves. Right. So I would say that there needs to be an understanding of how we reimburse for the social determinants of health, right? How do we reimburse for those activities? How do we reimburse for taking care of populations of patients that have been historically excluded before, and generate the metrics to measure that? Because if you're looking at measurements of populations that have not been cared for decades and decades versus a population that has access to healthcare since the time they're born, they're different. The outcomes will be different. So you have to look at different metrics of success.
Right.
Yeah.
So I know it's a long question that individual asks. It's a complicated question, but it's very, very involved. I'd like to hear if there are any others thoughts on the panel.
Well, that's a great answer, and we got about 6 minutes left in the segment. So I know it goes. So we cannot get through a health segment without talking about COVID.
No way.
So we got to talk about COVID. But I want to look at this. I want to talk about it from the perspective of, has COVID changed healthcare? Because we already talked about, has COVID changed education? Has it changed the working world? Give me no longer than about a minute if you're going to get that through that. And has COVID changed healthcare? So
for the good or the bad? Because there's
way.
some good things could come out of it and some bad. So
either way, Donna, starting with you.
Oh my gosh, has it changed? Absolutely. Again, I have to, because I'm in the education space, I have to take it back to that place.
Yeah.
It's exposed a lot of disparities that I think the general public had not been aware of before.
Right.
Which again comes back to why, as a community, African American patients, Latino patients, Indigenous American patients are suffering at greater numbers than white patients, which again comes back to social determinants.
Yeah.
Right.
Awesome. Awesome. Miss Mary, your thoughts?
Well, everyone knows that COVID has a special place in my heart. I lost my brother of 64 years of age, professional Black man, college graduate, Greek organization, philanthropic leader in the community in New York City. COVID. Has it changed us? I think that just on the most familiar level, I think that COVID began to open the eyes of our community and other communities as to just how vulnerable and fragile that we are to infectious disease. I fight at least twice a day to get a patient to take a shingles vaccine, yet alone a pneumonia vaccine, or just the regular flu vaccine on regular schedule from, I don't want to get, or child immunizations. I don't want to take those immunizations because I don't want to get sick. I think it gave everybody an understanding of infectious disease and how quickly, I think in America, we've been shielded from that. In other countries, we see it much more rampant, but I think it gave everybody a different perspective of how infectious disease can kill thousands of people at one swing. And I think it was very unrealistic to us prior to that. Did that answer your question?
Yeah.
Yes, absolutely.
Yeah.
Absolutely. Rocky, and then Jerome, if you guys will wrap it up for us.
Yes, and again, thank you all for this. And I don't know if I'll have an opportunity before we leave, but thank you for this opportunity, Tammy and John. How COVID has impacted us? Absolutely. It is, as I talked about earlier, it is provided a springboard with the tragedy and the disproportionate impact to people, Black and brown people. It has also afforded us an opportunity to cut through the regulatory challenges that were out there. I won't go deep into that, but we were able to move those things out of the way so that we could actually create mobile sites so that we could perform testing in underserved communities. It's also afforded us an opportunity to move forward with making sure that our program that we have for the Village Heartbeat, that we continue to move that work forward. The Village Heartbeat, as Sister Gaffney mentioned, affords through our churches and our institutions of higher learning, institutions of faith, and our Mecklenburg County partners in that public health, the opportunity to actually check BMI, to check A1C, to assist them with bringing those pre-existing conditions down, so that they can have a better experience if God forbid they came down with COVID. So it has actually springboarded and accelerated a lot of the work that we're doing. And it has certainly held us accountable to the outcomes that Jerome mentioned earlier. You can't manage what you can't measure. Thank you.
Awesome.
Nice.
Jerome, they put you in a 30-second box, so you got to go fast.
Yeah, so what it's done for me is about a year ago, I discussed with our team at Novant that we're laying the foundation for change. And the foundation that is most in need of change, that is most difficult to change, will be structural inequities, meaning rules, regulations, and policies that are in place. That was a year ago. Because of COVID, it flipped it upside down. And so what do I mean by flipped it upside down? It has given me the understanding that those rules and regulations are just smoke and mirrors, that they can be gone like that. As Rocky alluded to, there are a bunch of rules and regulations that disappeared for a short period of time in order for us to take care of patients in a rapid fashion. Those rules and regulations that we recognize now are all smoke and mirrors. So as far as I'm concerned, every rule and regulation that puts up a barrier for taking care of our underserved communities, I'm challenging every step of the way. Every day I'm challenging a rule and regulation that has been out there for some time. And I say, well, why is it here? If it's a barrier for taking care of our communities. So that's what COVID has afforded me the opportunity, is to challenge all of these rules and regulations that are obstructionists to deliver care to our communities.
Thank you, thank you, thank you, everyone. Our time goes by so fast.
Oh my gosh.
So we really appreciate you joining our 11th segment of the YBLA Conversations. We hope you gained some insight about the racial disparities in our healthcare system. We want to thank our amazing panelists. Thank you guys so much for participating and just enlightening us with your experience and knowledge on healthcare. We also want to thank our wonderful partners of DHG.
Awesome. What an awesome segment.
Yeah, it
Oh
was.
my God. So the next segment will be on Monday, November 2nd, not Tuesday, because Tuesday, November 3rd is election day. So we do not want to get in the way of anyone voting. So please get your souls to the polls.
Yes.
We will convene again on November the 2nd to talk about financial racial disparities among Blacks.
That's it. So please tune in, as John said, next 2 weeks, Monday, as we continue to move towards system level changes and to work towards our 2020 actions.
Do some actions. Get some actions.
So please don't forget to visit our website and participate on all the calls of action, even if you didn't get a chance today. Hopefully you did, but please continue to support us with that as well.
You guys are so awesome. Thank you all for joining us. We will see you next time and have a wonderful, wonderful day.
Yes.